So thank you very much. And thank you for asking me to talk today. And it's actually quite nice that I'm following up after Lawrence, because I suspect there's quite a lot of similarity, though we're looking at two different diseases. So today I'm going to speak about MERRF, myoclonic epilepsy, ragged red fibers. And as most of you on this call know, that it's an extremely rare disorder, can appear in childhood, adolescence, adulthood, right throughout the disease and lifetime spectrum. Whilst I say it's rare, we know that mitochondrial disease is perhaps one of the most common neurometabolic disorders, with roughly 1 in 5,000 people affected. But MERRF is exceptionally rare, with perhaps estimates about 1 in 100,000 actually affected. Any system can be affected, but the very distinguishing features around MERRF are always around myoclonus, which are muscle jerks, sudden brief spasms that affect, movement, but also other aspects like epilepsy, ataxia, difficulty with coordination, and over time, a slow decline in intellectual function. And what I'd like to present today is perhaps where we were when it was first described back in the 80s and where we are now, and why the whole clinical trial paradigm and clinical trial readiness is so much embedded in phenotype. Because in my experience, I'm now in the mitochondrial field from 2007, 2008. What I was taught when I first come is certainly not what we recognize now. The power of international collaboration is truly pushing what we know both clinically and experimentally around a lot of these very rare diseases. So let's think about the genetics, and as I said, we all are quite aware here that the first description is way back around 1980. And we know it's taken over the subsequent decade to identify the mutation that most commonly causes MERRF. And why that's important is because it helps us not just to give a diagnosis, but it helps us to have an idea about what the phenotype might look like, what the prognosis might look like, and hopefully also give better insight to potential targeted therapies. But my talk today is more about how we're trying to get ready for trial readiness, because when I was preparing for this talk and I looked up all the clinical trials that are available to MERRF, it's exceptionally limited. And I think part of that is around the complexity of clinical phenotype and the issues around correlation of heteroplasmy. So as you know, I've just gone through a bit of a brief understanding or introduction of what the complications might be, predominantly muscle, CNS. But the truth is, the more and more cases we see, the more and more they don't just resemble their original description, which was around myoclonic epilepsy and this abnormal function within muscle cells that appears as ragged red fibers when stained and viewed microscopically. So I'm going to show you a family and the diversity within a family that most of you probably have already seen. But I think understanding even the complexity within the family tells us how difficult our mission is to find a curative therapy for MERRF. And whilst there are treatments to treat the manifestations, that's why surveillance is important. That's why it's important to follow these patients up, because there are treatments we can use or direct towards the symptoms. Curative therapies are some way off, but actually the power of coming together, hopefully as I go through the talk, will become quite evident and how we're getting a better understanding of the diseases. So the first one I'm going to present is this young lady. She presented one of the first cases I saw around 2008, and she presented to our genetic screening clinic with optic atrophy. To come into the clinic, and it was actually optic atrophy screening. So it was due to an index case that was noted, and she was brought in. And when she was in, it was noticed that she'd subtle myoclonus. So we did the EEG that I put up, and any of you astutely looking will spot that the rhythm strip at the bottom shows that there is a likely reentrant tachycardia. And then we did an ECG, and lo and behold, she's got WPW. And when you start thinking about that, it goes outside just the optic atrophy, you start spotting patterns. So for us, to be honest, because of our experience, we went optic atrophy, myoclonus, and a WPW. There's very other few things that might be within a genetic clinic that's highly suspicious of mitochondrial disease. But I suppose I introduced this concept because the truth is, she came in supposedly with a little bit of visual problems, and really only because an aunt had an issue with optic atrophy. So clinical examination is vital. Documenting natural history is extremely important, and actually clinical examination. Sadly, over time, this person is actually deceased. The disease accelerated quite rapidly, where she moved from myoclonus to epilepsy to fulminant ataxia, wheelchair dependent, to dementia. And as we're increasingly seeing, that most of these patients die of cardiorespiratory failure. Her mother actually hadn't been seen at the outset. Her mother lived in another region of the country. We invited mum to come along, and it was very evident that once we'd seen mum, that you're thinking, oh, well, if we'd have seen her first, this was quite evident, because mum had myoclonus, ataxia, quite rapid dementia, because over a 6-year period from this photos, there was an absolute acceleration of the disease progression, where she was, when she first came in, she had a bit of past pointing, a bit of difficulty with upper limb dexterity, and within 6 years was wheelchair bound and had quite severe dementia at that stage. As we always do here, as Lawrence does in his cohort, and most of us here on the call, we then reached out to examine other family members. So the son of the last patient and this brother of the first to the index for this presentation, he then came along. He's perhaps one of any of you have seen Andy or any of my other colleagues present, always show this, because he had MERRF tattooed onto his arm, because he said, if I'm ever taken in, I'm tired of people asking me what's mitochondrial disease and they don't have an idea, so I thought I'd tattoo it to my arm. But they still call us and asked us what it was. And again, interestingly, so when he first came in, his main issue was around dysarthria. But again, similarly, so, almost as when I'm teaching around MERRF, there's almost that feeling of anticipation, because presented at an earlier age, more aggressive disease, rapidly progressive, rapidly developed myoclonus and epilepsy. And sadly, he too died quite tragically, again, most likely of cardiopulmonary failure. So across one family, the disease is quite extensive. It's multi-system. There's a lot of impairment of your ability to coordinate muscles, be it in your vocal cord. We definitely have seen patients with dystonia in their vocal cords that perhaps isn't as recognized in the literature. But over time, this disease aggressively progresses. And whilst quite often people talk about aspects of myoclonus being cortical, the more and more of these cases we see, I think more and more I'm adamant that actually it goes beyond cortical, subcortical, and likely spinal cord. And therefore, the usual therapies that we use are quite often really poor. So most of you here that have seen these patients, when you've got the photosensitive myoclonus, you'll use clonazepam, valproate, levetiracetam, and isoprimidone. We have exhausted all of these, and the truth is, the disease always outruns the medication at the start. Our experience is, diazepam, clonazepam are quite effective, but I'm afraid as time goes across and the disease progresses, these quite often really are poorly tolerated. So the next thing that's not infrequently seen is myopathy. And as a lot of our patients may have an underlying myopathy, quite often in the UK population when they come in, the predominant clinical phenotype is myopathy. Is ataxia. But what I'm going to show with our international collaboration, that's not what we're all seeing internationally. And therefore, if we were to target a treatment that was only for seizures, or target a treatment that was only for the cerebellar component, we would be doing a huge disservice to the myopathic patients and vice versa. So MERRF is exceptionally complex in how it presents, and myopathy and muscle weakness obviously is something that a lot of the current trials target. And perhaps that may be why in international centres, MERRF appear to meet the criteria. But for a lot of our patients here in the UK, the myopathy is not a prominent feature. And the other unusual thing that we quite often see in MERRF are lipomas. And this centre has done a lot of work, as a lot of my colleagues internationally have, is try and get an understanding of what they are, why they occur, what the brown tissue, adipose tissue actually means, and what implications that has for people who have that. So obviously, if you walk into the clinic, you see that they've got a bit of deafness, they've myopathy or myoclonus. MERRF is quite more easily to diagnose, but that's not, again, what we often see when they come in. And what those lesions absolutely represent, they're extremely vascular. What are they actually doing, and what are they telling us about mechanisms? And we have recently been looking at that to try and get a better understanding. Is, are they informing us about mtDNA and about actually how mitochondria are functioning at that level? And as I've alluded to in the family cases, the other thing that I've found very fascinating is when I've looked at the phenotype is that these patients can often have scans that mimic other disorders. So the closer and the more, and I say it's rare, but the more I look at them, Alexander's disease would be on the differential. So you look and they've got brainstem and cord atrophy. And these patients often come in acutely and they die quite rapidly of cardiopulmonary failure, which whilst myopathy is a prominent phenotype and while diaphragmatic involvement is important, I think commenting in our group that we've perhaps missed the central component to this, particularly in patients that present quite acutely with cardiopulmonary failure. And yes, when I deep dive in the literature, you go to 1989, Japanese had already, that's what they described as a terminal event. So whilst we're fixed on the myopathy and what their muscles do and what their breathing muscles do, actually there is most likely an underlying cardiopulmonary drive aspect to the terminal event. And again, why is that important to know? Because if we're, where are we going to intercede across the lifespan to get curative treatment, to get effective treatment, even just to give symptomatic treatment? So hopefully, as I talk through those different cases and the different presentation, that gives you an idea of what our challenges are as we go for trial readiness, for effective outcome measures, but also for effective therapeutic strategies. So in this next bit, I'd like to present international collaboration work that my colleague Yi from our centre is leading on with our Italian collaborators and right across all the cohorts internationally. We hope to relook at this and obviously reaching out now for that international perspective from Germany, Italy and the UK. And I think this is the bit that I find most fascinating, is because we can look at, the cardinal features are there that we all would expect with MERRF. So epilepsy is prominent, myoclonus, ataxia, myopathy, cardiorespiratory, increasingly recognized in lipoma. There are other aspects that perhaps we mightn't have recognized as readily and we may not have thought about as much. So things around, the respiratory function, aspects of dysphonia and dysarthria that are not just cerebellar. So aspects of a dystonic component to that, because that's a different management. But what is really interesting is we've all looked at our data combined and here from Newcastle, when you start deep diving on the phenotype, functional impairments, so the aspect of the everyday aspects of functioning that is important to the patient, is quite often driven by the cerebellar aspect of the ataxia in our cohort here in Newcastle. And aspects like, the myopathies or cerebellar and neuropathy, it's not that they're not prominent, but they are driving the functional impairment. So that again, it's telling us about mechanisms. But why, again, is that important as we're trying to be trial ready? Well, as we all move towards employing real world evidence and real world data to inform and improve both individual patient care and the design of our trials, this is the real world data that we need. This is deep diving to give us a better understanding how we're going to measure. And the truth is, when we've now deep dived in this for MERRF, this is not relevant to other disease groups. There is overlapping aspects that may do when you use the new technologies, but they're not devices that are currently approved by things like EMA, FDA, or MHRA. So if we're doing things, for example, validating wearable devices, what we're championing here in Newcastle and what YE is trying to look at on our cohorts are things like your ability to measure walking ability, your changes in gait using wearable technology, and looking at that kind of motor function in context of a person's episode, so where they are in their own environment at home, to provide a more accurate picture of the potential impact, not just of a future treatment, but what is our environment also doing, the potential impact of the environment as well. And really, when we look at the whole ecosystem of clinical trial readiness, you cannot separate those aspects of the environment and real world data. So the beauty of us all collaborating internationally, giving very small patient data, is beautifully exemplified by even simple things of knowing what's driving the functional impairment. And also, as we deep phenotype across the different cohorts, looking at what's different. And the differences across the cohorts in a general aspect are, when we see patients in Newcastle, it's biased because a lot of ours appear that the predominant phenotype is ataxia. But when we step back, it's because what we were seeing is we were looking for families and across families. And we all know that different phenotypes can run in families. When we compared our data with the Italian cohort data, there was a more prominence of a myopathy. And again, that made us stop and check and go, okay, if we're going to devise technologies and wearable devices as we prepare for futuristic clinical trials, myopathy and how you best measure myopathy is exceptionally important. Can we adopt some of the technologies that are currently being devised in other phenotypes or other aspects of neuromuscular disease, as well as mitochondrial disease? And then, as we all do, what other aspects may be impacting the phenotype? When is that transition from being affected, being carrier? And some of you may go back in astonishment. When I first come here, I was first taught that at 90%, anything under, unlikely that of a heteroplasmy, unlikely that someone will be affected. But the more and more we look, the more and more we all internationally look at our what would be deemed unaffected or carrier status, we start picking up people. It definitely more intermediate heteroplasmy with good clinical acumen actually are clinically affected. And mapping them now across their lifespan has hugely informed us about the aspects of clinical, when you become affected versus the carrier status. And certainly the bar has changed at what heteroplasmy level that might reflect. Disease burden, not unusual when we combined our data, that the higher heteroplasmy, the more likely disease burden increases. So I don't think nice to corroborate that, but not telling anybody what they wouldn't already know. But interesting when we start to look at predictors of disease burden and trying to deep dive at what might predict what that is. And again, looking at how we better educate the patient, how we can better capture data as we trial. The aspect of this, which was really nice when we combined this and things that we hadn't thought about before, was FVC, was respiratory function, was telling us something that perhaps we ourselves here in Newcastle certainly didn't monitor. We look at FVC, but is that the best way of measuring respiratory function when there appears to be a trend And as most of you know, if patients with MERRF have facial weakness, doing an FVC is perhaps redundant in the clinic because they won't get a good enough seal. So again, this has made us champion and start looking at different ways of measuring respiratory function using, either sniff or MIPS or MEP. So other ways that other disease groups are looking at it and trying to validate that within our patient cohort. Other aspects of disease burden, no different than anything else. So as you get older, your risks obviously increase. But as you can see in this, when we looked at different cohorts, aspects of ataxia can drive it, myopathy can drive it, perhaps less likely some of the other things that we would all look like. But once you have seizures, generalized seizures, the outcome certainly is telling us disease burden is higher, and the outcome is certainly not as good as it when you don't have seizures in that cohort. And perhaps, just in summarizing, what's really lovely is when you deep dive back in the information, what I'm presenting today is really new. When we've collaborated across the groups, it's interesting to see that it validates what you've published before, is that there are different aspects. So our cohort in Newcastle reflects a little bit more what the German cohort looks like versus the Italian cohort, which is more myopathic. So as we all come and pull these rare cohorts together, and we're informing either farm companies or ourselves as we devise new treatments, new therapies, and design trials, as we pull the data together, we will be better informed and be able to better inform the design of trials. And as I said to you, that last aspect of measuring things like FVC and blood heteroplasmy is something that we are looking at using different ways of measuring, different technologies, and certainly coming out of COVID is how can you measure meaningful things in real time and capture functional data remotely. And one of the things currently we're championing is looking how you can look at respiratory function remotely. So really, in summary, hopefully I've taken you through, whilst I propose to talk about clinical trial readiness, sadly, MERRF often do not qualify for the current clinical trials out there, but the future is bright because we're all pushing forward. By us collaborating internationally, deep phenotyping, looking what's prominent within these diseases, and within this small group of patients will further drive and inform our outcome measures. What's been really, really helpful is that international collaboration and pulling the numbers together, because if we work in silos and work in cohorts, we all might miss that bigger picture. And also, as we work, we're learning from each other and we're pushing technology to its absolute limit. And the truth is, as we engage with the EMA and the FDA and MHRA and the regulators, validation of what's meaningful to patients, and being very clear that the aspects of, when we are looking for curative therapies and treatment, it must be patient-centric. The outcomes must be patient-centric, patient meaningful. And what's, again, another thing we have been working across Europe is what's called the IMI Prefer study, is where in the pathway should the patient's voice be when you're devising these studies. Resoundingly right across is what we're all doing is right from the offset, because it has to be meaningful. So I'll leave it there, and hopefully I've given you a feel or an overview of some of the aspects that we are looking at from as we drive trial design, but also as we're working internationally with most of you here on the call. Thank you.